All right. I know that still people are coming in, but I don't want to I want to get started because we have a pretty packed agenda for this morning. Well, for today, depending on where you are in the world. For those of you who don't know me, my name is Stephanie Cohen. I'm a pediatric emergency physician at Emory University and Children's Healthcare of Atlanta, just a couple of miles from the CDC, which hopefully will turn around under this new administration. Today we have a wonderful opportunity to learn about the use of POCUS, which we all love for global health and in resource-limited settings. We're going to start out with our keynote address by Dr. Trish Henwood. We're going to hear from some providers who are working in those resource-limited settings and some of our more local providers who have gone to those resource-limited settings to help teach and educate on POCUS. And then we have a few announcements. I just want to thank all of our presenters this morning. We really appreciate your joining us this morning, putting the time in to put these presentations together and to share your work and experience. I want to thank our executive board, especially Magali Gothay and Erica Constantine, who were instrumental in helping connect with presenters this morning. And Erica will talk a little bit later about what P2 is doing with global health, and she's put a lot of dedicated work into this. We have a QR code here, and in the chat box, we're going to put in the link for the survey as well. If you could take a few minutes during the conference, after the conference, to fill out the survey, that will be immensely helpful for us in planning future conferences, as well as give feedback to our presenters who put a lot of time and effort into these presentations. I want to take a minute just to mention, kind of where we are. During our last presentation, our webinar back in November, COVID cases were spiking, and it seemed like it was really out of control. But within a year of when we first saw COVID, we actually have a vaccine out, and many of us have had the opportunity to be vaccinated. And this was a huge global health effort that really is going to hopefully turn things around and get us out of this pandemic. And like I said, many of us have been lucky to get the vaccine, and wanted to just highlight the importance of global health. And now I'm going to turn over to our keynote speaker to talk a little bit about how we can use our tools in global health. And I'm going to invite Dr. Erica Constantine to introduce Dr. Henwood.
Hello, everybody. Thank you for joining and welcome to our webinar. It gives me great pleasure to introduce to you Dr. Trish Henwood. Dr. Henwood has completed her medical school at Jefferson Medical College in Philadelphia, and she did her residency in emergency medicine as well as an ultrasound fellowship at Brigham and Women's Hospital, Mass General Hospital in Boston, Massachusetts. Since then, she has been tremendously impactful in the global health sphere. And among her numerous accomplishments, she is the founder of PURE, which stands for POCUS in Resource Limited Environments. It is a nonprofit dedicated to ultrasound education and research in the developing world. She has also led the development of expansion of clinical ultrasound programs in Rwanda, Uganda, Liberia, and Tanzania. She has served as a medical director at the first Ebola treatment unit launched by a US-based humanitarian organization, and has played a major role in the humanitarian response to the Ebola virus disease epidemic in West Africa. She is currently an associate professor of emergency medicine and the director of global strategic partnerships at Thomas Jefferson University in Philadelphia, Pennsylvania. And because of her background in disaster and outbreak response, she's now leading the emergency medicine COVID-19 response across 10 EDs in the Jefferson Health System. So without further ado, I'm very pleased to announce Dr. Trish Henward, who will be speaking to us next.
Thank you so much for the introduction, Erica. Just going to get my screen share going. Can everyone see that okay? Okay. Thank you guys for having me today. I'm really excited to talk to you about my experience with point of care ultrasound and global health. Just a quick disclosures. I run, as Erica mentioned, the nonprofit Pure. We have had some equipment support and I do some consulting and have some research and other funding support. Really excited to talk to you guys about the work that I'm doing. I had a meeting the other day with someone in compliance actually, and they said, oh, we love how passionate you are about your work. And to me, that meant that I often give them trouble bringing something at the last minute that needs to get done. But I do think that it's a key to be able to be successful in this kind of work longitudinally, because it's challenging, but I think also really rewarding. And really looking forward to talking to you guys about my experiences with this today. If you have questions, please feel free to put them in the chat, and then I will follow along and pause for questions at different points. So I think that ultrasound plus global health and the combination of pediatrics is really something that is a transformative combination. The idea of limited diagnostic imaging in settings where there is really limited access, regardless of what type of imaging that may be. When we think about the pediatric population as well, the idea that you baseline want to avoid ionizing radiation in those patients, as well as the ability to do digital image transformation and tele-ultrasound programs, which is something that I'm working on now and working on actually with the P2Network, and really excited about that. So I think this is really a time where emergency medicine and pediatric emergency medicine, in addition to the intersection of ultrasound, is really innovating and educating in this space. And there's really a ton of potential. I think that the idea that these technologies are now even more portable and durable, and the transport of them in terms of training, as well as the lower price point that we can consider for use in this setting, is really relevant. From my perspective, this is a little bit of a slide that I think speaks a little bit to my career to date. And I think that within the last couple of years, from my experience, I think we've really seen a tipping point of ultrasound at the point of care in resource limited settings, and the recognition of how important that can be. I first started doing this work around 10 years ago. And I think at that point in time, to me, it just was, when I co-founded Pure, it didn't make sense almost that there weren't more people focused in this area, considering how beneficial I found ultrasound to be in a field context for the work that I had been doing. And really, I think there was a bit of an uphill battle in terms of convincing people. And I think now we're at the point of trying to really convince large funders and create the research that actually supports the impact that I think we see anecdotally and clinically when we're helping with training programs or using ultrasound at the point of care in settings without a lot of other resources. I think in recent years, we have actually crossed that tipping point in terms of both the technology being more affordable so that programs aren't as expensive, and just the recognition of what we can use ultrasound for. I think in the pediatric space, this group is at a really exciting point from my perspective, because I think that this is where it's growing, similar to how in adult emergency medicine, there had been the infiltration of ultrasound into point of care use in all of our departments. I think that as more and more people get trained in the space, then it makes more and more sense to kind of expand the reach. And so I find it to be a really exciting time with what this network has growing. And I think that it just, to me, makes even more sense in the pediatric population than even the adult population. So I think that it's a really exciting intersection. And again, this is sort of the diffusion of innovation perspective. I think that you guys can speak to this perhaps at the end, where you feel like POCUS is on the spectrum, but I think that we are moving along this in terms of the diffusion of innovation, particularly on the device side, which I think has allowed for the acceleration of programs. A lot of my work is focused or has been focused in Africa. In my current leadership position, I'm focused both on activities and programs across our country partners in Latin America and Africa. But most of my training work in ultrasound has been focused in several different countries, mainly in East Africa. And I think one of the amazing things has been really working longitudinally and seeing the impact both of training in emergency medicine, and then when we layer on ultrasound at the point of care, and how that has changed and really transformed care. The combination of these things, I think, has been so impactful. And I know later you'll hear from Vincent, one of my colleagues in Rwanda, and watching the growth of emergency medicine specialists and then actually experts in the point of care and the local capacity, and how that has really impacted care has really been amazing to witness. I think just want to pause for a second and see if there's any questions, Stephanie.
No, nothing yet.
Okay, perfect. Feel free to chime in or interrupt if anything coming up. So I think the most important thing in thinking about bringing an ultrasound training program or supporting an ultrasound training program that's getting going is that while people may have really good intentions, it's also important to think about not doing harm in the context, and thinking about what applications one would consider incorporating, what is going to be the follow-up for those, what are the local management patterns and capacity, what are there things to act on or not act on when considering how, and also the sustainability of the device and the equipment and the backup, and that all of those are pretty critical to thinking that you don't want to actually cause more of a challenge by introducing ultrasound to a setting. The safety considerations, I think, are really key and an important starting point in recognizing the limitations of ultrasound. I think, we're all sonophiles and love ultrasound, but I think recognizing that there is often the ability to significantly narrow a differential, but not necessarily to make the final diagnosis by ultrasound. That this is an operator dependent technology. I think that's, part of our huge challenge in terms of training. And, while there's a lot of efforts to move towards AI and other approaches to kind of limit some of that operator dependence, there's still limitations in how those algorithms are developed. And I think it's still really important to have the integration of good image acquisition and quality and the clinical interpretation. For that to happen, I think that quality assurance programs are very important. It's really challenging to figure out the balance, I think, of time and how supported a program is, and how much of that quality assurance you can do sustainably in terms of 100% support, getting people to a certain threshold, and then following up with X number percentage of studies. I think it's a similar thing that we grapple with in our emergency departments locally as well, in terms of how much of the images need to be reviewed and how that impacts the quality of the program. So it's just, I think, something critical to this success, and very much the approach that myself and most of my colleagues working with Pure are adopting, things from looking at really creating quality and sustainable programs, making sure that our local trainees or trainers have that additional consultation support whenever they have a case coming up. Again, it may be pathology that they're actually more familiar with ultimately managing, but doing some of the challenging image interpretation and remote support is something that we found really helpful to sustain a program. And then, as I was mentioning, the equipment piece, I think this is really challenging in terms of local availability for biomedical engineers, and what devices can be addressed or troubleshooting for issues locally versus machines that might need to get sent international for repair, and how that can impact a program. So trying to think about the fact that that could happen at any point in time, and making sure that you have your connections fairly dialed for how you're going to address device failure. Because ultimately, once ultrasound really takes off in a setting, there becomes a lot of dependence on the technology. So I think that's an important consideration. The Pure model overall, and I think the basis of the work that Pure and myself have been doing is really looking at things from a needs-based perspective. I think that the advantage for being minimally funded for a long period of time is that we end up being very driven by by what the local need is, not by some external funding call necessarily that's dictating what something needs to be, but trying to determine with our partners what are the areas that they're struggling with. In Uganda, the internal medicine ward really struggling with the idea that the DVT ultrasound was only happening a couple days per week when a radiologist was there, and that it was actually very expensive for the patients and something that was cost prohibitive, but something that we could easily teach in terms of a 2-zone compression, for example. So not necessarily focusing on AAA because of limitations in local management, and it wouldn't change. So trying to determine really what the needs are for our partners and the sites where we're working. And we don't have any cookie cutter approach to the curriculum. Definitely a choose your own adventure depending on what the patient population and the providers are demanding. I think the importance of the approach that we take is really trying to develop local faculty. And I think that's what actually makes these programs sustainable. I think programs that have funding, or significant funding, that's often for a finite period of time. And if you do not create the local capacity, it ends up being, I think, a drop in the bucket over time. So our model is really focused on partnering and creating those local faculty instead of thinking about just training a huge number of people that might not ultimately have access to a machine, for example, but really thinking about who are going to be the leaders in ultrasound, who are going to be the champions for ultrasound, that we're going to transfer this skill building for how to teach ultrasound, not just teaching ultrasound itself. So the train the trainer context, I think, is something that we've been successful with and find very rewarding, obviously, in seeing that there's actually the local capacity to take over. And when we become less relevant, when I don't need to be in Rwanda anymore, I think to me that's the success of our programs and part of how we measure it in terms of becoming remote supporters or intermittent supporters while things are really locally sustained. And the same thing on the research side. I think that the context-specific research questions are really important in driving things, and not something that is necessarily the way that academic research funding works, which can be a challenge in getting some of these programs funded and initially up and running and sustained. But I think it's also has been important to the success of not overlaying an external non-mandated initiative into a setting. Any questions, Stephanie?
Nope.
Okay.
You're good.
Just having a little slide trouble there. 1 second. There we go. I think you guys know, the importance of POCUS and why in terms of the all-in-one. And the value in this, obviously, I think all the pediatric applications that you would think of normally in any setting, in addition to things that we train on in peripartum care and obviously volume status and infectious disease is something I'll talk about a bit, as well as procedural guidance. I think the procedural piece in terms of quality and safety is something that we can often help make an argument for ultrasound in terms of getting devices for procedural safety, but then obviously kind of growing the applications that we're working with from there. I think, as Erica mentioned, we have supported programs in several different locations. The first location where Pure started was in Rwanda, and then expanded to Uganda from there. And those are two of the countries where we've continued to work very heavily over time, and where we currently have some tele-ultrasound activities going. I think that the importance of ultrasound across the spectrum is something that I wanted to highlight today, both in terms of our emergency departments as well as field hospitals and then international hospitals. The ability to incorporate ultrasound at the point of care combined with ultrasound and care outside of a hospital setting, I think are really interesting, and something where I've focused a lot of my time. Just in speaking a little bit about pandemics and an example, I think, of the idea of where ultrasound can play in. This is a quote from the former Minister of Health in Rwanda. And we know that a global pandemic response will only be as strong as the weakest country, and pandemics are just outbreaks mishandled. This is really how I ended up ultimately getting involved in Liberia and in the Ebola response to the West Africa epidemic, as Erica mentioned. This was a time in 2014 when we saw cases escalating, and there was fairly little international response in terms of the need for clinical support in the context. I initially actually got looped in because of a consideration of ultrasound use in Ebola treatment units, but then ended up pivoting to actually just a purely clinical deployment, or focused on a clinical approach, because there was such a demand at the time, and then became just a volume consideration of needing support. And I had inquired about using ultrasound, but it was not something that was felt to be relevant or useful when I went. And so I went without an ultrasound. This was at a time that cases were really, I was in Liberia, and cases were really escalating at that time, and we're really at the peak. Right now, when I look at these numbers, it seems like sort of otherworldly when we compare them to COVID, and the impact of COVID, and the sheer numbers that unfortunately that we've seen as a result of this pandemic. I think that part of what we were trying to do was obviously containment based on the mortality associated with Ebola, and the context of health systems, particularly in Liberia, where there had been intermittent periods of civil war, and really significant influence on just sort of the basic needs in terms of roads and education. But there was really a process of slow rebuilding that was happening. So Ebola really struck at a challenging time in terms of a fragile health system. And when I ended up actually working, this was our treatment unit in Bong County. This was formed on a former leper colony. So this was just sort of popped up with these different buildings. And it was very, very challenging because the patients, essentially, we didn't really have a great idea of the pathophysiology, what was happening in terms of why some patients were dying and some patients weren't, really variable clinical courses. And too many sunsets in Liberia. The gravestones say sunrise and sunset. So I think that was part of the challenge of being a clinician in that context, and seeing so many sunsets, but not having a great idea of why we were seeing such variability in our patients. In the context of the time that I was working in our ETUs, it was basically 50-50. And you knew that, every day the patients that you admitted, that at least half of them were not going to walk out, which, as you can imagine, is a really challenging context when you have really limited resources. The variety of presentations we had much less hemorrhagic initially in certain sort of pockets and areas. We would have patients come in with hemorrhagic conditions, but most of the time the context seemed to be hypovolemic, and then, suspected electrolyte derangement from patients that were seeming to improve and then had sudden death. But then there were some other contexts, which I'll get into a little bit, that were a little bit confusing as well. And so it was really, as clinicians, we were trying to figure out what's happening and how can we advance care in this setting. Once we got to a point where we actually had more staffing, and we felt like this isn't just purely a containment effort right now, we really need to try to find a way that we're going to actually improve care for each and every one of our patients in this setting. And that's when I was able to actually very quickly get an ultrasound device to bring into the ETU to try to see if we could figure out what was going on with our patients. Because again, clinically, we were just kind of stumped with the variety of ways that patients would either slowly decompensate or very quickly decompensate, or seem to improve and then suddenly get febrile and die, or would be fine and then suddenly die. And so it was very, very confusing. And this was me actually in our physician and clinician treatment area, training some of the other providers. So talk about just-in-time training. Once the machine went into the hot zone, it did not come out. And so it was important that we took the time out of PPE because of the heat and considerations to do some training outside of the treatment unit before the device went in. scanning, obviously, in goggles and a sweaty contacts is very challenging in and of itself. So we knew that, it was going to be harder for other providers, but for some of the basic assessments that this may end up being useful for other clinicians in the setting and not just myself. And I think one of the questions that we had was these patients that were seeming short of breath, and it seemed that they were more tachypnic than short of breath, but it was hard to differentiate. We had data at that time, patients in high resource setting that were getting imaging along with their resuscitation were having volume overload type of picture and third spacing. And so it was one of the questions for us when we're trying to give IV fluids, for example. Those would need to be done very quickly because we can only stay in the treatment unit for a certain period of time and have to monitor the patients when they have IVs in. We can't leave them and then go like we would, doing rounds on a ward or in our emergency departments. And so trying to determine if we were potentially exacerbating volume overload, or these patients were third spacing, and did we need to actually give IV fluid slower, or could we give them more in the periods of time that we were there? And indeed, we saw that they looked actually quite dry, A-line patterns on their chest x-rays, really flat IVCs. And so that helped us decide that, it made sense to actually try to not worry about the volume overload that we were seeing in settings of very high volume resuscitation, because we just didn't have the capacity to do that in our setting. I think one of the most surprising or interesting things that ended up coming about was learning that some of our patients that had that rapid decompensation that I mentioned actually, seeming to improve classic Ebola symptoms with high volume diarrhea and GI losses, and then seeming to move in the right direction. But I had several patients that then developed, what seemed to be a peritoneal abdomen, febrile, at times altered, and trying to figure out what was happening with them, and putting the probe on and seeing that in several of these patients, we saw these dilated non-peristalsing edematous bowel loops. And when we correlated that with some of the culture data in settings with higher resources, which was usually a gram-negative sepsis, then it gave us the idea that actually, there was probably a secondary bacterial infection and a translocation situation going on here, and ended up initiating antibiotics for those patients. Ultimately, as time went on, treatment units that incorporated empiric antibiotics, patients had lower mortality rates. So it's, something at the time we just thought, okay, this is, a viral process. Antibiotics aren't going to make a difference. And, it's one more thing to worry about. We subsequently realized this actually, there's something different going on here, and that there was more concern for secondary bacterial infections, and treating patients more aggressively made sense in terms of at least trying to see if we could get ahead of that. Because obviously, once you have a patient in a treatment unit with very little resources, who may have a gram-negative bacteremia, you're already in a losing battle there. The other thing was a lot of liver pathology in terms of this sort of starry sky, increased echogenicity of the portovenules, and inflammatory process in the liver, and hepatomegaly and such. So again, it was, ultrasound ended up providing a window into some of the pathophysiology and care of these patients that prior to being in that setting, was not thought it was going to change or be of value. But being a clinician that's used to working in settings with limited resources and having the skill set, I think made a difference in how we decided to manage our patients at our treatment unit. Similarly, for our pregnant patients, this was really important because the concern for, even when mothers would end up testing negative, that concern for transmission across the placenta, and the fact that when they would deliver, that could present a threat to their home or community or site where they were delivering, and maintaining these patients in an ETU, depending on where they are gestationally, is a really challenging consideration, as you can imagine, for really everyone in the situation. But if they're very far from potential care, if they live in a village that's remote from a hospital, then there's a risk of what happens when they deliver, or if they end up having a precipitous delivery. There was also obviously fetal loss associated with Ebola, and trying to convince mothers at time for induction if there was concern for fetal demise. So using ultrasound to actually be able to show the mom that there was no longer any heartbeat, and that this wasn't going to, go on to be a normal pregnancy, I think helped us in times of concern for the consequences of a septic abortion, for example, and dating gestational age for these patients, trying to decide, how long it might be until they deliver, and how to decide about the management for them if they were actually cleared of their infection. And this was really more a matter of pregnancy management. Any questions?
No.
Okay. So from there, I think around this time is where I sort of pivoted a little bit more to a bit of a research focus. Part of that was from frustration, I think, from treatment or management guidelines that came out with very little data, particularly on those pregnant patients, as I mentioned. So we had several patients, as you can imagine, if you are in the height of an epidemic and then you have abdominal pain and bleeding, then you may end up being, a suspect for Ebola, but really that may just be a complication of your pregnancy. One, if you're not actually confirmed. Two, there was a perspective of non-intervention because of the risk for healthcare workers from infection of the fluids and sort of that risk. And that was very challenging, as you can imagine, clinically to not intervene when you felt like there could be something done that might actually save the life of the mother in the treatment unit. Again, still limited resources and limited context, but I think something that was important for us and my team, and we ended up doing this retrospective evaluation across all of our ETUs in West Africa to show that there wasn't actually evidence that there was an increased risk of death for pregnant women compared to those that were non-pregnant. So that this concept of non-intervention because the mother is going to die was not actually sort of reasonable. The other thing, in using ultrasound in the context, you can imagine getting images out as well as some of the data considerations. It wasn't possible and good for the Ebola epidemic that when I went back to West Africa after my first mission to continue to work on some of the ultrasound questions, we had much lower patient volume. And so that led to us not having a lot of sort of data to be able to report this in a research context, but at least did a write-up thinking and reporting on what we found ultrasound to be useful for in the context of care of these patients, and continue to incorporate this a bit in working with other groups in the DRC. And there's much more ultrasound incorporation in that context moving forward now. So I think another area where ultrasound has sort of moved over the tipping point in terms of the recognition of value in the context when you don't have other imaging to answer any of your questions. From there, just in terms of kind of the spectrum of where I think ultrasound can have value, I ended up actually focusing on some health system strengthening efforts in Liberia because we recognize the ability to incorporate ultrasound in our ETU made us actually have somewhat advanced imaging that, in many settings, it may be limited to just plain X-ray, or the X-ray machine may be up or down, and that actually more ultrasound use in the hospital setting in Liberia was going to be of significant benefit to the patients. At the time, there was no functioning CT scanner throughout the country. And so really ultrasound was going to be the highest level of imaging that was available. And there were only a few radiologists throughout the entire country in terms of providers that could actually perform ultrasound or incorporate it into their care. So I think this is another area where we found that kind of the spectrum of ultrasound in these different settings and across this continuum from a disaster setting into a post-disaster and a health system reconstruction effort, it was critically relevant. Back to just sort of some of the general considerations, somewhat what we were talking about earlier, just when thinking about how to incorporate this, thinking about the partnership. So it was really important for us to be working with local hospital leadership, with the Ministry of Health, with our colleagues in pediatrics and internal medicine and surgery. In Liberia, emergency medicine doesn't exist as a specialty. So trying to actually make sure that we found the ways to integrate this into different specialties in how they were caring for those patients, in answering the most important questions that they had, and where this could make a difference. Just in terms of some of the broad considerations, I know that a lot of you guys are working on training programs and have experienced these aspects, or for people that are thinking about engaging in an effort or starting a training program with a local partner, that there's a lot of pieces that I think are relevant, in addition to the needs assessment component that I already discussed in terms of the locally driven efforts. Just thinking about some of the logistics of the training, and how you're going to do that, and what assessments may happen for those patients, follow-up assessments for the trainees themselves. Thinking about the funding that may sustain this, and do you have startup funding but you don't have any funding that's going to get you to the next step? Does it still make sense to start the program at that point in time, thinking that it may come through, or you want to wait and build more funding so that that you can sustain the effort longitudinally and have backup for the device, for example. And then research considerations, if you're incorporating research into the context or into the training program, or looking at outcomes, just the considerations in terms of timeline for that, and the time it takes for ethical considerations, language barriers that you have to think about with consenting patients, and follow-up considerations on the cohort, are all very challenging. So this is just sort of a little smattering of the different pieces that, if you're at a starting point or growing something that started small and you're thinking about the different pieces that go into it, I think these are all really important considerations. The train the trainers piece, I think, has been, from my perspective, one of the most rewarding aspects of the work that I've been doing over the last couple of years. This is our group that includes some pediatricians, as well as surgeons and family medicine and internal medicine physicians in Liberia, who were so happy to be able to gain the skill set of ultrasound and feel like they could take better care of their patients. So I think that the passion that we see from our trainees in the settings, and I think several of whom you'll hear from, at least some of my colleagues in Rwanda and potentially in Uganda, is definitely what keeps us going in the challenges, I think, of getting these programs going. This is our group in Rwanda, the emergency medicine group that I work really, really closely with. And they are a bunch of star pioneers in emergency medicine for sure. This is Olivier is one of the earliest graduates of emergency medicine in Rwanda, and one of our earlier trainees in ultrasound. And this is him actually when I was at the Brigham, working with my fellows and training them about how he uses ultrasound in the context. And to me, and my role now, my university role working on global partnerships, I think it's critically important that these are really two-way streets and bilateral connections, and what my trainees can benefit from in having someone like Olivier come and teach them about the burden of disease and the clinical context that he's working with, I think has been really invaluable. There's a lot of different pieces that we put together in terms of the approach that we've taken to either research or quality assurance programs. Just a shout out to Ben Smith and his Sano ClipShare pathway is something that we were able to secure image device and review, and that's something that we've used, as well as a number of different devices in helping to support some of the tele-ultrasound efforts that we're working on in Rwanda and Uganda at the moment. And then just, one more switch gear of, how many places can ultrasound end up incorporating itself for different roles. As Erica mentioned, I'm now helping to lead our COVID response across our health system because of my experience in disaster and outbreak response previously. And I think it's another place where my experience in global health and in building programs in ultrasound has actually become very valuable skill set to draw upon. my entire life. I think Erica or Stephanie in planning with me for this has been pretty challenged over the last year, ever since really we ended up with our first local cases. And I've been working really closely with our incident command pretty much on a daily basis for almost a year now. Back to that pandemic quote from our former minister in Rwanda, we obviously see the challenges of how the pandemic has been handled in the United States, the stress that's put on the health system, and surge considerations that we've had to deal with, I think, at different periods of time in different ways. And initially, this is sort of what my life looked like in March in trying to set up field tent settings, tent triage, and obviously with my background, ultrasound was going to play a critical role in that, getting our tablets and getting the devices online, biomed support, and the whole process so that we could actually use ultrasound outside of the hospital and helping to triage, who had any abnormalities that we thought needed to go in for further evaluation in the ED. This is one of the testing sites that I helped set up in terms of our mobile testing sites for the health system itself. And then this was one of the designs that we had in creating the flow for our triage and how we were going to move patients in and out. This is physically outside of our emergency department out front. We were particularly challenged because of our city location and geography and just extremely limited space in trying to figure out how we can create extra physical capacity and maintain distancing considerations. And these were some of the devices that we had online in terms of working through our triage algorithm and where they would play in and making sure that we had things that were portable and could get online to be able to save images and to triage and manage patients from there. This was one of our triage protocols where we were incorporating ultrasound and determining who was essentially going to be going into the ED for further evaluation and further imaging, or who we felt like was safe to send home in the context. I think ultimately we were lucky enough that our volumes, our surge conditions never got so unmanageable that we couldn't actually bring people in, we could bring everyone into the department that we felt needed to get further evaluation, and we didn't have to do sort of a mass casualty approach to triage ultimately, but we did have this kind of worked into how we would make decisions if we had to, and obviously hope we do not get into the situation ever again. But I think just an example of how the experience in working in low resource settings, because that's what a lot of our settings became when we looked at the number of beds versus the number of patients, PPE conditions, testing limitations, and how we make decisions really played into the leadership role that I've been playing with our enterprise response. A lot of my work has been focused on outreach to our local vulnerable communities. I'm running some of our city testing sites and helping with community outreach in the city now. And really, I think all of those roles are things that were born out of the experience that I had in working in settings with limited resources, as well as the number of different pieces that are required to get ultrasound training programs, I think give you a lot of different perspective than just a clinician that's taking care of patients at the bedside. So the kind of program building aspect and the operational experience that provides. Shifting gears to sort of the area that I was focused on heavily before COVID, and something that I've been circling back on recently, and what I'm working on actually just after this, presenting actually some of our work to the Gates Foundation on Thursday for this study evaluating ultrasound as a screening tool for pulmonary tuberculosis. So I've done some research on ultrasound for extrapulmonary TB with our colleagues in Rwanda. This study is actually layered upon the Vukuzazi population health study in South Africa with the African Health Research Institute, and looking at the difference in patients that had either symptomatic or not symptomatic TB or no TB. And so we're doing some data analysis as we speak, and doing a little bit of a teaching session with the foundation on Thursday to show them these subpleural consolidations and different types of pathology associated with TB that you can see on lung ultrasound, which has been really interesting. And then some of my other work is actually getting going a contrast enhanced study for trauma. I think that this is the future from my perspective of ultrasound in settings with limited resources and without CT availability. If we can take ultrasound and basically make it better with the addition of contrast, and we can get the cost of contrast to come down, if there's sort of more demand in a different context for its use, then I think that that's something that really has a lot of potential. And has been a bit of a process because it requires clearance from the FDA in Rwanda to do. This is supported by some of the leaders in contrast enhanced ultrasound in the US from Boston Children's. So they're funding this study and working with our local EM colleagues to work on essentially comparing contrast enhanced ultrasound to CT in that context and how it performs when being done by an emergency medicine physician. And then last effort that's been pretty active at the moment is ultrasound training for COVID with my colleagues in Uganda. So again, this would be a bit of a tele-ultrasound effort combined with a group called Imaging the World Africa. And there unfortunately is rising COVID and limited diagnostics in a 1-week turnaround for PCR in the setting. And so trying to help them with training for their intensivists, and then those intensivists will become the trainers that work on training medical officers and others throughout their isolation unit. So a very kind of timely effort and something we're trying to get together actually pretty quickly because of the increasing burden of COVID, unfortunately in Uganda recently. So hopefully that was a nice foray across the different areas where I think that that ultrasound can play into work in the global spectrum, as well as just settings in general with limited resources. Again, I think the pediatric context, I just can't see any place that it makes any more sense than the fact that it is already such a valuable imaging tool for pediatric patients in settings with any resources. So I'm definitely happy to take questions and discuss with you all, but excited to have the opportunity to tell you about all the work that I love doing.
Well, thank you, Trish. That was really wonderful. I really enjoyed learning and hearing about all your different projects. We do have a few questions, and just following on that last point that you mentioned about the isolation unit in Uganda, how did you deal with infection control and the risk to physicians, especially when you were in Africa and during Ebola?
Yeah, I mean, I think that that's obviously the huge tension, and for any of these things, this is where there always has to be a risk-benefit equation in how or when you're incorporating ultrasound. For the Ebola treatment unit, that's exactly where I got pushback. It's why I was told, not to worry about ultrasound initially. It's where there had to be a lot of conversations with our leadership of risks that they perceived to me for being in the ETU longer and scanning and spending any additional time than was necessary. So the approach to that was that I could essentially only scan at the end of my rounds when I felt like I had sort of the bandwidth of, okay, we've done everything that we need to get done, and now I can try to scan the patients that I think that it's going to be the most useful or valuable on, or I'm the most confused clinically about what's happening with them. And then I think it was something over time that there became more acceptance of, this is actually an important component of caring for these patients. But I think for people that don't sort of see or recognize the value of ultrasound, I can see inside this patient, I can have so much of a better sense of what's happening to them clinically or pathophysiologically. It was a challenge. And, the same thing in the context of scanning for COVID. And I think that it's someplace where that was a major consideration of how we would use ultrasound in the setting, and where using it out front in a triage context of who we might be more concerned about that might need to come into the ED, or do they need more imaging if we're in a really high volume, barely sustainable situation, is a different conversation than just scanning everyone in the ED when they could, get, I think there's an argument obviously for ultrasound and its value compared to chest X-ray, but deciding what imaging they're going to get inside the department when you can decide, it could be an ultrasound, it could be an X-ray, it may be a CT depending on the setting. and doing research in that context is something that's challenging and was a big conversation at the beginning of the COVID outbreak as well, then became pandemic, I think, of what we knew about it, what the risks are, what the risk benefit of incorporating ultrasound is. So I think that, it's always an important conversation to have, and it's a definite tension in thinking about the risks that you might take. But I feel like there's also the argument to be made in terms of, the benefits for a better understanding of what's happening with your patient and or what's happening with the disease process, which is, I think, things that we've learned with ultrasound in both of those contexts.
I think, of course, you're preaching to the choir here. We all here know that ultrasound is definitely helpful in evaluating the disease process. What was your experience as far as the reception to education in these resource-limited settings, and how enthusiastic were your learners, and how does that compare with your experience in training faculty and residents in the United States?
That's a great question. I think most of the programs that I've been leading are really locally driven, and so I think that the enthusiasm has been very high because I think that there's the recognition of a challenge, just as I felt so challenged in that ETU setting of what is happening with this patient. The fact that then I could get an ultrasound to try to see and get so much of a better understanding. I think that that's the experience. I see Vincent on the line, that, someone like Vincent or our colleagues in Liberia, they were so passionate about training for ultrasound because of the difference that it can make in the clinical care of those patients. So I think that it's different sometimes for us. And, I was a ultrasound fellowship director, prior to my current position. And sometimes with residents and trainees, it can be a little bit more pulling teeth because it can be easier to order a CT scan or, to get the MRI or to order an ultrasound from radiology. But if you don't have that option, then I think the approach to how much, the enthusiasm for learning ultrasound, I think, is a little bit different. There's always the tension on the time investment, right? There's that upfront time that it requires to get up and off the ground, which is definitely, can be hard when you're working with a high volume patient population and limited time when you don't have a lot of resources in a setting. But I think I've seen so many trainees really go, the extra mile in terms of training and learning and offline and any and all hours to try to build their skills.
And then the last question, and one of the things that I think that was very difficult for us with this pandemic, and we've found some ways around it, is we're not able to travel, we're not able to go places and network and teach the way we used to. So what are some recommendations that you can share as far as to how people can continue this type of global POCUS education in our era of COVID?
Yeah, I think for me, interestingly enough, things have gotten probably busier than quieter as a result of the pandemic. And I think that that's not just because of my COVID leadership role, but it's because everyone has moved into a virtual world. My colleagues that I'm meeting with in Colombia, they're not with each other in a room either. My colleagues in Rwanda are not in a room with each other either. Everyone is getting together virtually. So I think that's normalized, this kind of approach and made us innovate in the way that we educate, and the idea that there's so much that we can do remotely. We can minimize the time necessary, reduce our carbon footprint, still relate a lot of information that we would in person. The hands-on training consideration is obviously a challenge, but I think that leveraging local resources. So, getting something going from nothing is hard when there's not someone that can do kind of the haptic component of image acquisition. But I think when there's some local training capacity, for example, in Uganda, the program, sorry about the noise there. the program there, we have one kind of major focal point in terms of someone that's going to lead the hands-on training for this smaller group, and then we have a fleet of people that are supporting the program remotely and doing some of this tele-ultrasound training component. So I think that there's a lot of ways, actually, with existing relationships and with any local training capacity, that you can really help buffer that, provide support for didactic content so that local faculty don't have to be making new lectures on things, and trying to grow the relationships in that way. And I think that so much of this work, it's about the relationships and it's about the support and the bilaterality. I think it doesn't have to be about standing next to someone on the ground, though.
That's really great. I want to highlight, you mentioned putting lecture series together, and we're going to touch on that from the P2Network a little bit later on. But I just want to thank you, Dr. Henwood. This was a really fantastic lecture. I really enjoyed learning about your travels through your work and how you used ultrasound to help in these situations.
Thank you so much for having me. I definitely look forward to continuing to work with you guys moving forward.
All right. So now we have the opportunity to hear from one of Dr. Henwood's colleagues from Rwanda, Dr. Debumwinama Vincent, and I hope I'm saying that right. He's the Program Director of Emergency Medicine and Critical Care at the Colleges of Medicine and Health Sciences at the University of Rwanda, and the Head of Department of Accident and Emergency at Kigali University Hospital. He is also a fellow of the Ultrasound Leadership Academy and is a tele-ultrasound program coordinator and POCUS trainer with interest in ultrasound education and clinical research. He has shared a video with us, but he is here live to answer questions as well. Oh, hold on a second, I'm sorry.
Program. Thank you very much. My name is working at one of the Lefelo teaching hospital, Kigali University Teaching Hospital. I'm the current acting head of department and as well the program director for the emergency medicine and the critical care program. Today I'm going to share with you the cross-departmental POCUS mentorship in the setting with limited radiologists, and I'm going to talk more about the practice at CHIK. Thank you for inviting me for this important conference, Pediatric Emergency Medicine Point of Care Ultrasound. I'm pleased to be part of this meeting, not only to share my practice, but also learning from what everyone is doing. So as introduction, the POCUS point of care ultrasound serves as one of the diagnostic imaging, which is essential in providing specialistic level care, like ours at Kigali University Teaching Hospital, to manage the undifferentiated patient from acute illness to the trauma patient. Rwanda currently has 8 radiologists and 7 cardiologists. The CHIK is, as a public hospital, has 4 radiologists working full times, and mainly those ones are operating CT scan, X-rays, and ultrasound. The POCUS is the only solution to overcome the radiology department overwhelming, looking on the number, the ratio of radiologists versus what they have to do as part of the daily activity. So you can see on the left side, we use it in several ways, including diagnostic, but also therapeutic. You can see like my resident assisted by the the fellow ultrasound, trying to do the fascial nerve block. Looking on the pediatric imaging in Rwanda, the pediatric has a little bit difference compared to the rest of the population when it comes to the imaging. This is the paper which has been done by one of the visiting radiologists, where I found that the sonography is being the most frequently used imaging modality throughout the hospital, because it can be available in all departments, whereas the rest, like the X-rays and the CT scan, which need to serve most all the country, as the only one referral hospital in Rwanda, it's getting it's getting limited access when it comes to the frequent use. So the same principle does apply to pediatric population. You can easily use the ultrasound to make a preliminary diagnosis when the CT scan or radiology are not yet available. So looking on the POCUS in Rwanda specifically, the point of care ultrasound is not such all the practice in our settings. We started using it back in 2013. You can see myself when I was trained by some of the pure fellows about the ultrasound. So this time I was a resident, like almost 2 years back before I graduate. And since then, it has become an integrated part of the practice, especially for the EM providers, since we have been almost the only one who have got this opportunity to get training on the point of care ultrasound. Pediatric POCUS again, looking on our accident and emergency department organization. So we don't deal only with adults, but also the pediatric population. When they are traumatized, they do consult our department. Likewise, when our residents during the training, they have to go to the pediatric department for the clinical rotation, where the use of the ultrasound, they have to exchange it with the peer pediatric residents. Again, when it comes to the diagnosis which are identified during the single rotation of the EM physician to the pediatric department, we have been able to diagnose the patient, the pediatric patient who were having tamponade, and we successfully performed the pericardiocentesis. So we have been able to diagnose some of the cases which were presenting with massive pleural effusion requiring chest tube, and you have been able to start using the ultrasound guided IV placement, which is most of the time very difficult when it comes to the pediatric population. So pneumonia versus cardiac cause of shortness of breath, that is the hallmark of this, the ultrasound used in pediatrics. Most of the patients presenting with shortness of breath, you can easily get to differentiate, is this patient having cardiac origin shortness of breath or respiratory origin shortness of breath. Again, part of our sharing, we had to wait. We are like other emergency department. We do have to consult specialized care, like a specialized unit for patient admission. You can see like this one who was presenting with shortness of breath, and using the ultrasound, we were able to diagnose the possible origin of the shortness of breath within the department. And the same practice does share the two internal medicine when they consult. You can see on the right side that this patient was not only having like cardiac cardiac thrombus, but also he was having disseminated thrombus to the pulmonary vein. You can see here that the patient was having the D sign, which is showing the increased intrapulmonary arterial pressure. Looking into the other department which does consult, you can see surgical department does consult the emergency department, and we do share our practice with them. This case, you can see the left upper quadrant, the patient who was presenting with post-trauma, and we were able to visualize the organ injury to guide the surgeon in case they wanted to go to theater for surgery. Looking to the rest of the patient who does present with undifferentiated condition, this was a patient who presented for the left hand and forearm swelling post-fall. It's really difficult to know maybe if someone is presenting with swelling and the pain post-fall. Definitely you need to think about the fracture. The X-ray has been ordered immediately, and it provided limited information. Whereas when it comes to the ultrasound, we ruled out the fracture and the making a differential of an infected hematoma which has been collected, and it has been tapped successfully. So you would imagine if without the ultrasound, where they would have been limited only to the X-ray, and of course ruling out the fracture and leaving this corrected hematoma. So part of other mentorship we do as well is within the critical care and the ICU mentorship. The emergency medicine and critical resident program, part of the curriculum, has 8-month total rotation, and during this period, we have been able to initiate the practice of POCUS in ICU settings, starting from central and the peripheral line placement, fluid status assessment. Nowadays, you can see the change. Also, the ICU team, they are getting used to the administration fluid based on the ultrasound assessment. During this rotation, we do team up with the anesthesia resident, where they can run as well from our practice. So this was a trauma patient who had a pericardiocentesis arrest when we were attempting to do pericardiocentesis, because the patient was presenting in shock post-trauma, and after doing ultrasound, we found this huge accumulation. And unfortunately, after the pericardiocentesis, the patient died 2 days later from severe lung contusion. But at least there is no doubt that this patient would have died on the first day if a pericardiocentesis was not done. So you can see that the IVC was a pretoric, and which is showing how the heart was not able to move the blood forward. The other mentorship we do as well is the tele-ultrasound mentorship, where we use a program installed into Rumify called the React, where we can interact with international faculty to discuss a certain image. So this was sometimes back when I was testing about the use of React along with my mentor. Thank you very much, Dr. Trish, who presented recently, discussing about the the imaging, the cardiac imaging. So nowadays, having this practice and most of the people passing through the emergency department, we are able to interact with the rest of the provider in a district hospital using WhatsApp. With WhatsApp, this was a patient you can do like the X-ray, which was done in district hospital, and the patient was, they wanted to refer the patient for thoracentesis. So, and after discussing with internist, I advised him, maybe instead of referring the patient to thoracentesis, simply you can put the ultrasound and see if it is maybe mass or a polycystic effusion, which has been revealed. So the management has changed immediately. Instead of referring the patient for thoracentesis, they have to refer the patient for the CT scan to investigate possible cause of this like septated effusion, and which was followed by cardiothoracic surgeon exploration. So again, this was like on the right corner side, you can see like my one of the intern working in the district hospital who was concerned about the findings from the scanning. So to him, he was saying that he has done the ultrasound of in the right flank side of the patient, and he found the above imaging, I'm sorry, is not well visualized, and he thought on having that the patient was having mass. Unfortunately, when I reviewed the image, the video he shared it to me, I realized that the patient was having polycystic kidney appearance, and I calmed the concern about he was not really confident that the patient might have a polycystic kidney disease. He was worried that it's like a regular mass simply because the urea and the creatinine were normal. So from that, I have advised well to consult urologist, which will be different scenario when he haven't shared this image. So looking on multidisciplinary consult again, we do have gyne and the obs benefiting from our point of care ultrasound practice. You can see like this side where the patient was coming from district hospital complaining of abdominal pain, like the pelvic pain, and she was not able to pass stool and gas. He was passing gas, but there was no stool. So the usual investigation to rule out the intestinal obstruction, the routine one would be X-ray, which hadn't revealed anything in terms of air fluid level. So when I put my probe, I realized that the patient was having hematocorpus. And when I checked again, when I checked the patient with the history, she told me that she have never got menses and she was at 16 years old. So, and we had to divert the patient from gyne, from surgical to gyne and obs, and thanks to the ultrasound. This is a case which has been reported again following a patient who presented with a feature of peritonitis, and also they were worried about having a horoviscous perforation. But after putting the probe to rule out the free fluid, I found this gas shadowing in the uterus, and requesting the pregnancy test. The pregnancy test became negative, and the gyne and the obs were like, they were reluctant to admit the patient, because when the pregnancy test is negative, so they always become reluctant to admit. So I was telling them that they have to admit because the uterus needs is showing a feature of necrotic tissue. So it has been like argument because they were not able to believe our finding on ultrasound. So later on, when they explore, like they did explorative laparotomy, because the patient was getting sicker and sicker, they found that the patient was having fundal uterus necrotizing endometritis, secondary to unsafe abortion, where she had perforated uterus. So the other option, we are doing mentorship. We have, unfortunately, COVID has disrupted this practice, emergence in the tropics, where we invite the worldwide trainees to practice ultrasound, and they can run more, since we have a lot of various pathologies to practice while you are learning ultrasound. So this was a discussion during one day of the EMIT course practice, and at least what the level we gave them, it's corresponding to the ultrasound level 1 UK-based ultrasound course. So on the right corner, this was back in 2018, where we had a big African conference of emergency medicine, and we had to organize a pre-conference on ultrasound. So you can see several participants. It was one of the top pre-conference, which has several participants. So as a conclusion, having experienced the practice of POCUS in CHIK, and I would recommend that we even practitioners do value the utility of point-of-care ultrasound, which we have tested and adopted into our practice. Just to mention that the point-of-care ultrasound is useful for 4 angles, if I would say, starting from resuscitation, diagnostic, symptoms and sign-based procedures, guidance, and the therapeutic and monitoring as well, as I mentioned, where the fluid administration is based on the ultrasound fluid assessment. So point-of-care ultrasound growth possibility is rely through the interdepartmental collaboration, as when you are doing a concert, and we do want to inform the admitting team to the findings. They need to know some of the basic and to understand the approach we are using. The Rwandan next effort for a point-of-care ultrasound development is focusing on research. We are dreaming as well to organize a boot camp series for young generation, likewise to the practitioners, to inform them the basic of point-of-care ultrasound. And also nowadays with the curriculum review, the University of Rwanda is integrating this into critical care training as part of the ultrasound being part of the critical care training teachings. Thank you very much. I want to close from here, expressing what I always say to my trainees: express the love to the probe, and it will express the love back to you as well. And of course, it will praise you to when to help you to save the life of the patient, which the hallmark of the practice when we of the time we spend in the emergency department. Thank you very much.
Thank you so much, Dr. Vincent, for joining us.
Thank you very much for your kind.
I'm very impressed with the extensive nature of your program and the high level of care and pathology that you're able to use. Okay, we're running just a little bit behind, so I want to bring up our next presenters, Dr. Beth D'Amico and Liliana Morales-Perez. Dr. D'Amico completed fellowship training in pediatric emergency medicine and pediatric point of care ultrasound at Baylor College of Medicine, Texas Children's Hospital, and is currently a member of the faculty in the section of emergency medicine at Children's Hospital, Colorado. She has been involved with POCUS and resource limited settings since her fellowship when she rotated in Dar es Salaam. She is also involved with POCUS education in the United States, Haiti, Malawi, and Panama. And Dr. Morales-Perez completed her fellowship training in pediatric emergency medicine and point of care ultrasound also at Baylor College of Medicine, Texas Children's Hospital. She also completed fellowship training in global health at Baylor College of Medicine, Texas Children's Hospital, and a master's in public health with a concentration in global health at UT Health Science Center at Houston. Dr. Morales-Perez is currently an assistant professor at the University of Puerto Rico and Baylor College of Medicine. She is involved with POCUS education in Panama, Malawi, and Puerto Rico. She is currently working to develop a pediatric POCUS program and curriculum for pediatricians working in emergency medicine and critical care in Latin America. And both Dr. Morales-Perez and Dr. D'Amico are co-founders of the Pediatric Global POCUS, which I hope they will share with us, and is on the ultrasound leadership group of the Sociedad Latinoamerica de Emergencia Pediátrica. So without further ado, thank you.
Thanks so much. I'm Beth D'Amico, and Lily is going to be running our slides. You might know us. We are undertaking a project as well, doing a pediatric POCUS webinar. So we speak often together. We're great friends in real life, and so hopefully this goes well with her running the slides and me speaking. We're going to talk briefly about a couple of experiences we've had expanding POCUS use in pediatric acute care settings worldwide. So our first project was in Malawi when we were both working at Texas Children's. Lily was a fellow and I was an ultrasound faculty member. And we were lucky enough to be able to go with the support of our department to work at Kamuzu Central Hospital, which is in central Malawi. It's a referral hospital. Just so you get an idea of the sense of the clinical abilities, they admit about 40 to 120 children per day. There are some specialty services, including neonatology, cardiology, HIV care, hematology oncology, and nutritional rehabilitation. And they are equipped with oxygen and some limited CPAP. And if you're lucky, for some kids, a ventilator for reversible causes. The next slide just kind of shows some of the clinical environment that we work with, and which some of you might be familiar with. So records are all on paper, including your orders, vital signs, medications, and the patients actually hold on to their medical records. In the left-hand corner, you can kind of see the CPAP corner, where if you need CPAP for a child, you kind of go and try to retrofit some things together until you can get some oxygen and some support for them. And like a lot of places, there is a shortage of space and beds for the number of really sick kids. So there's often multiple kids in a stretcher at one time. So we were fortunate enough to work in Malawi through Baylor College of Medicine, the section of pediatric emergency medicine, which partnered with the Malawi College of Medicine and Ministry of Health, as well as other United States children's hospitals to form a partnership. Basically because most of these institutions had been working in some capacity in Malawi since 1999, but had not been coordinating our efforts to best promote the goals of the ministry and the Department of Pediatrics. And so we were providing support for the development of emergency care and acute care for children through this organization called Pachimake. One of the unique things is that because of the different institutions working in Malawi, we were able to get some information and do a needs assessment and work clinically before we undertook any projects. This is just a nice example of one of the pieces of the needs assessment that was done by folks from the University of North Carolina. So they actually looked at a death audit over about a year and were able to see some of the causes of death and some of the resource limitations. And so you can see there's a seasonal variability related to malaria in the rainy season and food insecurity. Overall, the mortality rate was somewhere between 2 and 4% of the patients, which is quite improved. The last known mortality rate there was about 9% from a study in 2012. One of the things that they found were that delays in care were significant for patients, particularly in the first 24 to 48 hours. So there were a lot of patients who were ordered x-rays or ultrasounds or consultant requests that didn't receive those. And we thought that this was an area that point of care ultrasound might help to alleviate some of these issues. We also performed a POCUS specific needs assessment. So while working clinically prior to any education endeavors, Lily, who had been there multiple times, and myself used the sonosite that was there and took requests for ultrasounds. We found that cardiac was our big moneymaker and that there were quite a large proportion of kids with poor cardiac function or structural abnormalities, particularly undiagnosed congenital heart disease. We also interviewed clinicians to see what some of the challenges were. Obviously, there were multiple pediatric emergency medicine fellows, residents, and faculty rotating to provide clinical supervision. All had different levels of comfort with POCUS, as well as a lot of the challenges that many of you are familiar with, limited access to electricity, machine durability, Wi-Fi, compensation and time for the learners who were interested in learning POCUS. And then also there were limited opportunities for folks who were working in Malawi to see how POCUS was used in other settings from a clinical standpoint. So we developed a training model using a lot of Dr. Henwood's information from some of her programs and needs assessments. When we started, our idea was that we were going to have basically an algorithmic scan based on local provider input and some knowledge of what the local disease burden was, so that we were performing, for example, the same POCUS exams for patients in a routine manner. So one of the things that we saw a lot were swollen patients, and we saw a lot of diagnoses of nephrotic syndrome, when in fact there was probably a lot more malnutrition and rheumatic heart disease contributing to the swelling of these patients. And so we thought that doing perhaps a focused cardiopulmonary exam and a limited exam of the abdomen would be most beneficial. We were in Malawi for a month as consultants, so our responsibilities included rounding in the basically intensive care area that had monitored beds, as well as the emergency zone. And so while we were doing that, we identified trainees from the priorities of the department, and we basically provided lectures. We had lunch meetings, and we rounded with these folks every day and performed exams on our patients, as well as did teaching sessions in the afternoon. After about a month, we had one clinical officer who was quite competent and so was allowed to continue using POCUS in his clinical practice on a daily basis and used the ultrasound for another 9 to 12 months. We followed his scans and gave feedback using the Butterfly IQ platform. And we were able to actually certify him at the end of this based on the results that he got. And so we're hoping that he will be able to kind of move forward and provide some training for folks in the future. And we're a little bit at a halt right now because of COVID, obviously. We found after the initial 1 month that we were there, this is our trainee, his name is Fanuel Bachani. He's a clinical officer, which is probably most similar to a PA in our setting. So he performed about 260 POCUS exams over the 9 to 12 month follow-up period. Typically, the patients reported that they had no medical problems, although a significant proportion of them also had cardiac history, including most likely rheumatic heart disease, as well as HIV, renal disease not specified, and tuberculosis. Most common indications for his exams were swelling, cough, shortness of breath, and fever, and that's for exams across the board from cardiac to abdominal to lung. We were able to give him remote feedback using the Butterfly platform. So this is just an image, Lily giving him props for a really nice image that he took. And we found that his overall ability to take really high quality images with good interpretation ability as well. So most of his images, as you can see in the graph on the left, were on the ASEP scale from 1 to 5, 3s and 4s. So really, we were able to see that he was taking images that would help with diagnosis, and that he was pretty limited in the amount of technical flaws that he was making. And we did use, unfortunately, we didn't have a real gold standard in terms of imaging. So we used ourselves, we both reviewed the images independently, and we did our true positives and true negatives in that sense. You can see the blue part of the graph, most of his were true positives, and the orange were true negatives, and a much smaller proportion of false positives and false negatives. As most people are familiar with, there have been a lot of challenges over the past year. So funding is always a challenge. We did not have any significant funding. The COVID pandemic has prevented a lot of travel based on restrictions from the university. And we also found that in training Bachani, he, fortunately for him, had a lot of new opportunities in terms of moving into different sections within the hospital. So he was actually kind of usurped by the pediatric hemonc group because of his ultrasound skills. And so that's kind of where he is now. It's also challenging to sustain your equipment in a setting where maybe there is not the same capability to get repair and get new iPhones if you need one, et cetera. Last, we just have a very few clips of images that Bachani, our clinical officer, was able to obtain, kind of demonstrating the quality of images. So these were just a couple of patients that had trauma and presented to the hospital. Falling from a mango tree is a common complaint. So you can see both a suprapubic and a right upper quadrant view that showed some free fluid. The next one is some images of patients that were not previously known to have rheumatic heart disease. So again, these patients, I believe this was a 5-year-old who complained of some swelling and a little bit of shortness of breath for somewhere between 1 and 2 weeks. And so nice images just kind of demonstrating some decreased cardiac function and some mitral valve pathology, consistent most likely with rheumatic heart disease. Next, we're just picked a couple of images from a patient that's his only complaint was generalized edema. And so significantly, I think you're able to see on the left side, that was a parasternal long axis view demonstrating poor cardiac function and a plethoric IVC. So that information is obviously clearly helpful to the team to help sort of categorize where the edema, where the pathology is coming from. And I think this might be the last one. Obviously, quite a bit of tuberculosis, both pulmonary and extrapulmonary. Not a lot of literature about the use of POCUS in children. But on the left, a nice image of a patient with a pericardial effusion. Those were fairly common with some fibrinous material you can see off to the right side of the screen. And then on the image on the right, a nice picture of a spine sign with a significant amount of fluid above the diaphragm there. And then obviously there were many images that we reviewed that we maybe were not familiar with the pathology. And so kind of we learned a lot in this process consulting with Bachani and other folks who worked in the setting to help form differential diagnoses of maybe what were happening with these patients. And now I'll turn it over to Lily.
Hi, good afternoon. So now we're going to talk a little bit about our other site, which is Panama. So how we got to Panama is a little different than how we got to Malawi. So this happened from Orlando to Panama. So we were at the AAP, the POCUS workshop, and one of the physicians attending the workshop was from Panama and asked us to help. He was very interested in taking POCUS back to his institution and to Panama, and we started a relationship. After a couple of months discussing, sending emails and WhatsApp messages back and forth, we decided to plan a visit and go to Panama and help him with a workshop that he was trying to develop. So we ended up at Hospital del Niño Dr. José Renan Esquivel, which is in Panama City. This hospital has a capacity of, they see about 100,000 children per year in the emergency department. It is a super tertiary hospital it's the public hospital. It has a pediatric residency. It has the largest intensive care unit of Panama. It has the largest neonatal intensive care unit. And it has capacity for ventilators, inotropes, and resuscitative equipment. So before the workshop, we went and performed a needs assessment. This is the pictures of their emergency room. They divide the emergency room based on triage category. So in this picture over here, this is the area where they see the patients that are triaged as red. They have another area where they stabilize the patients that are triaged as yellow, as urgent. And then they have another area where they're the green stable patients where they're just waiting to be seen. They have a hydration unit where they place patients that need IV fluids. They have a respiratory room where they give oxygen and breathing treatments. And we also looked at the equipment that they had available in the hospital. So some of the challenges we found during the needs assessment and with interviews with the physicians and the participants of our workshop was that, like in Latin America, there's limited pediatric subspecialty fellowships in Panama. So physicians that want to specialize in pediatric emergency medicine or critical care have to go to different places in Latin America for their training. So some of our physicians that we met had to go to Colombia or had to go to Mexico to get their training. Therefore, pediatricians are the majority of the physicians that work in the emergency department and in the intensive care unit. So there's limited subspecialty services around the hospital. There's not a lot of cardiologists, there's no interventional radiology, there's limited pediatric emergency medicine and critical care doctors. So there's no true 24-hour coverage of subspecialty because of the limited amount of physicians they have. However, their doctors, their pediatricians have great clinical skills, great knowledge, and they're very eager to learn new skills to help their patients. When we looked at the equipment, there weren't any dedicated machines for the emergency department or for the critical care unit, but they did have available ultrasound machines in the radiology department to be used when the ultrasound techs were on. And there were also echo machines for the cardiologists to use whenever they needed to scan a patient. The other difficulty that we weren't anticipating was that in Panama, they have limited iPhone technology. And that is relevant because we had the butterfly equipment. That's what we took. And at that time, it wasn't compatible with Android. So most of the doctors in Panama only had BlackBerry. So we couldn't leave the butterfly. When we looked at the technology platforms that they had available, they didn't have any system for us to do quality assurance, but they were great at WhatsApp messaging like we were talking about before. So that worked great. So looking at the training model from Malawi, this was not a training model that we could follow because they were very different places. So that's one of the things we want to stress out. What worked in Malawi wouldn't work in Latin America and Panama especially. So the physicians here had done a lot of independent study. They had attended workshops in the past. They looked at YouTube videos. They did their own research studying about POCUS. So the plan was to go to the workshop and do the basic POCUS workshop, do some hands-on scanning with them, and then remote image review and feedback, identify POCUS champions, which we already knew one, which is the director of the workshop that we went, and then support those POCUS champions with their work and their education, and then come back to do advanced POCUS work with them. So we developed a basic POCUS workshop based on the necessities that they had identified and the studies that they would use the most. And then we came back about 6 months later and did an advanced workshop as well. So we did hands-on scanning. They had identified patients in the hospital that wanted to be volunteers for them to scan for their basic POCUS workshop. And then we had inpatient scanning with the advanced POCUS workshop in the different critical care units. So when we talk about QAing, Actually, the studies from Panama, they would record with their phones, their machines, and then send us through WhatsApp. And I say QA consultant and case discussion because as time progressed, they got really good at POCUS, and it was just them sharing their findings, their clinical cases, and how it affected the management. So this is a patient that they identify had a large pericardial effusion. So they used the ultrasound to identify the effusion, and then they directed the procedure. Some of the pathology that they see over there is very different than what we're used to. So they have this black scorpion that is very poisonous. And Panama is it's the second country with the largest envenomation secondary to scorpion. So they see a lot of myocarditis and fulminant myocarditis secondary to scorpion bites. They used to tell us how before getting into bed in some places in Panama, you had to make sure there wasn't any insects in your sleeping bag or your shoes before putting on your shoes because of the prevalence of the scorpion. So they would use the POCUS to identify myocarditis, heart failure, and then sort of direct therapy based on that. And that's a picture of how they shared their images and their thoughts with what's going on with us through WhatsApp. So the applications most commonly used in Panama are cardiac, lung, fast, and procedural. They use it for their medical management. And by their experience, the thing that they use it most is for fluid management. They identify if the patients have good cardiac function, they look at the IVC, and they direct fluid management and they also use it for vasoactive medications to start inotropes in patients. They use it for ventilatory management, meaning that they look for pneumothorax, they look for B lines, and they guide the pressures based on that. And like I said, they use it for procedures looking at drainage from the heart, drainage for the abdomen, pleural effusions, abdominal taps, and pericardial drainage. One of our privilege was that, like I said, they are very eager to learn. So in Houston, we had the Latin America Critical Care Summit, and our POCUS champions, which are these three doctors over here, came to Houston to learn more about critical care. And we had a POCUS workshop that they also participated. So we are hoping that as we move along, with remote teaching, we can also have bidirectional opportunities for our Panama colleagues to come to our different institutions and continue to learn, and strong partnerships with other Latin America countries or even within Panama that need help. So like Beth was telling you guys, we have a webinar called Pediatric Global POCUS. We are happy to have any of you present your cases while you're working abroad so we can learn from each other. Thank you for the opportunity to talk to you and share our experiences. And if there's any questions, we're here to help.
Thank you, Lily and Beth. That was really fantastic. One question is, how does the certification process work in the global health setting? Are there standards or requirements?
Yeah, we used, we kind of adopted the recommendations from ASAP and that we used for our PEM fellows. So we are in our PEM fellowship, we were both previously in Houston. The fellows had to obtain a number of scans in each category, but overall greater than 150 with greater than 90% accuracy of interpretation. And so that's kind of what we used. Our trainee obviously got 200 and some, so he way surpassed that. And we felt that he was obtaining good quality images in his practice. So we gave him sort of a certificate of certification that he could use in his hospital.
I think one of the challenges abroad is actually getting that to be a standard among different institutions, and who gives the credentialing. Is it the visiting institution or their own institution? We're hoping that in Panama, they're working to make it their own credentialing process and do it through them, which is the goal.
I think just to chime in there, Vincent, for example, in emergency medicine in Rwanda, they were able to kind of integrate that into a core aspect of their curriculum, actually. So I think there's this whole spectrum in terms of how it can happen in terms of credentialing in different contexts, which is a challenging sort of topic that we could speak about for hours, probably.
Well, thank you both for sharing those projects that you set up. They look really fantastic. And is there an opportunity for any of the P2 members here, if they were interested in participating once COVID is over? How would they go about that?
Oh, absolutely. Email us. If you speak Spanish, we'd love to have you in Latin America to help us out. Absolutely. If you don't speak Spanish, you can also learn to speak Spanish and help us with, with QA abroad. So absolutely send us an email.
All right. Thank you so much. I want to introduce our next speaker, Dr. Tal Berkowitz. Hold on a second. Dr. Berkowitz completed his fellowship training in pediatric emergency medicine and point of care ultrasound at Emory University School of Medicine and Children's Healthcare of Atlanta, and is currently a faculty member within the Division of Emergency Medicine. During his fellowship, Dr. Berkowitz participated in the Global Health Residency Scholars Program at Emory University and currently functions as the pediatric liaison. He also serves as a faculty mentor for residents and fellows who join that program. He has been involved and is currently involved with POCUS education in Tanzania and Ethiopia, and has been working on POCUS programs at those facilities.
Hello, so I'm Tal Berkowitz. Thanks for the introduction, Stephanie. I was just going to go through a little bit of my kind of background, how I got involved in global health, and I'll skip over kind of quickly through some of the background stuff and talk a little about what I'm currently doing with Ethiopia and Tanzania. So I sort of initially, prior to ultrasound, got involved in global health just from the PEM standpoint through the Global Health Residency Scholars Program, and now return yearly, of course, until this year, as faculty, with initially a lot of my work that I was doing in Ethiopia more related to resuscitation training in their pediatric emergency department and their PICU. And then found, of course, through that, one of the things the residents there were constantly asking about was using ultrasound for procedures, asking me to do ultrasounds for them and teach them ultrasound, largely in relation to resuscitation, but also diagnostic stuff in their emergency department. And so this was just sort of a typical image of the type of thing that we saw during my first visit there. Same thing here. And as some of the images that you've seen already, these were a couple of examples of tuberculous pericarditis. But a lot of the findings, of course, that we found there were rather dramatic presentations of some of the things that we might see more subtly here in the United States. So after my initial trip there as a second year PEM fellow, realized that it was going to be pretty helpful for me to get more ultrasound training and to be able to use that, I think, more as my niche in global health. And so that also helped lead to sort of forming some ongoing relationships, mostly in Ethiopia as far as those relationships. But this is Dr. Tigist Bacha. She and another Dr. Mulu Denburu were the two first pediatric emergency and pediatric ICU physicians in the entire country of Ethiopia, which is a country of about 100 million people. And so noting for them, it was going to be a pretty important task, I think, not just to be able to go over there and try to do ultrasound or teach ultrasound resuscitation, but actually try to get them to become champions within their, within their teaching community to lead a lot of the ultrasound that goes on there. So we were able, through some grant funding with Emory, to bring Tigist to Emory a couple of years ago, and she did a month of ultrasound training with us and simulation training with us to then be able to go back and try to lead some of the ultrasound training over there. Since each time I go now, it's for pretty short periods of time. And of course, the challenge I've realized is very difficult to do a lot of teaching unless you have someone there who can really take that part over. So Tigist has since also gone on to do an 8-month sabbatical in Israel in the cardiac ICU, where she's sort of been able to come back to Ethiopia with a bit of more echo training and ultrasound training that she gets to use. So just as an overview of that hospital, so Blackline, it's a very large tertiary care hospital. They have now 3 pediatric ED and PICU attendings. And so most of our ultrasound training that we do there is really focused on training those physicians. The residents that work in the hospital in the pediatric area are not generally ED residents, they are pediatric residents. And so not a lot of them have a final interest of going into critical care or pediatric emergency medicine. And training them really ends up being these short spurts of them getting small amounts of education that doesn't really last when it comes to ultrasound. And so I think one of the big lessons that we've learned in that specific setting has really been focusing more on the faculty members. And if they can sort of maintain their skills in ultrasound, they can go on to do some of the teaching themselves. The ED residents there, on the other hand, who again don't spend as much time in the pediatric world, have a lot of, are pretty adept at ultrasound through some of their own training. And then the biggest challenge with Ethiopia is really the lack of internet for the most part. And so even trying to do remote learning through lectures, through Zoom, and trying to get them to send us videos or watch them do ultrasound from a remote standpoint has been extremely challenging because their internet is not stable. Anytime there's unrest in the country, the government will shut down the internet. And there's not kind of a very good, stable way to get that information back and forth, unfortunately. So then I did ultrasound fellowship at Emory. And during that, I was able to travel to Tanzania and work a little bit more in their general emergency department, where they do have residents who have ultrasound training, and they have some faculty that are very good in ultrasound. But I was able to sort of focus my time there just teaching ultrasound to the residents to help build some of their skills and then get to know that hospital. So that's a general emergency department. Again, it's a very large national tertiary referral hospital, and their range of patients included trauma, cardiac patients, oncology patients. And I think what made that process work a little bit better is that it's ED residents who are constantly in that environment and are going to continue to maintain their ultrasound skills. This was just an example of some trauma teaching that we were doing in a workshop there. So now my main area now to try and teach ultrasound with Tanzania is that they are in the process currently of establishing a pediatric ICU at that hospital. And that PICU is going to be, it's run by general pediatricians. So there's 6 doctors, one of whom has some fellowship experience in pediatric ICU. They have 2 dedicated ultrasound machines there, but essentially none of the people there really have any prior ultrasound experience, and they currently don't use the ultrasound machines other than when radiologists will come to their department to use the ultrasound machines occasionally. So part of their curriculum goal now is for them to have some ultrasound education. And because the internet is much more stable in Tanzania and they already have monthly learning that takes place Wednesday mornings, we're now starting to do, they have weekly learning on Wednesday mornings. We're now starting to do monthly ultrasound lectures with them, with the plan that hopefully once travel can be reestablished, myself and our current ultrasound fellow will at times be able to travel there to do hands-on teaching with them. And so this is kind of a new thing for me, is figuring out how to do a bit more of a remote curriculum that at least starts through Zoom lectures, and then we'll be able to pick up hands-on learning. So a lot of the lessons that I've learned, I think overall for global health, but even related to ultrasound, is all of these types of teaching, and especially now with coronavirus, it's just a challenge when you're not consistently there on the ground. And so I agree with some of the other people, what they've also, talked about in their talks, is you have to really try and establish some champions at these sites so that they can really go on to carry on the teaching when you're not there. Ironically, when it comes to coronavirus, I think it has boosted a lot of people's capability in terms of Zoom learning and remote learning. And so it's actually made some of the remote aspect of this a little bit easier. But ultimately, I think you have to establish these ongoing relationships and have a way that they're constantly going to be able to get further education once you've established a program for them. So the current goals, so So from the standpoint, I think, of general goals, through P2, myself and a number of other physicians, Dr. Yera and me are kind of leading the curriculum part, the curriculum building part for P2. So we're trying to sort of establish a curriculum of lectures that can then be distributed, that don't actually require a lecturer to be present necessarily to give them, but that people will be able to at least use as a basis for ultrasound learning from a pediatric global health standpoint. And then for me, I think both remotely as well as on-site doing ultrasound teaching in the PICU at Muhimbili, I think will be a bit more of a stable approach for me to be able to have a core group of people that I can teach and who will be able to become champions in their site. And their priorities are a little bit different than some of the priorities we have in the emergency department. And so I think it also allows us to really focus down on things like airway for them to use ultrasound for intubation, cardiac, and then of course procedural for things like pericardiocentesis, central line placement, and then thoracic ultrasound as well. And then hopefully in the future, as we've done with Dr. Tigges from Ethiopia, we would be able to bring them as well. And I think having this two-way street when it comes to global health, where we try to actually have people from other places come to the United States to get some education here, and also to educate us on the things that they see, can really be a nice way, I think, to integrate both aspects of global health. And then hopefully while doing that, still be able to help the PEM and PICU faculty in Ethiopia grow their skills. And this is one of the other nice reasons, I think, to do global health. It's just the things you get to see, of course. Thanks.
Thank you, Tal. That's it's really exciting. I've told you many times I'm interested in when we can start traveling again. I want to go over there myself. Okay, and our last speaker of the morning is going to be Dr. Esteban. Dr. Esteban is a clinical officer for MSF. For those of you who aren't familiar with that, that's in English, Doctors Without Borders. He is currently working as an intersectional POCUS trainer for the MSF project in South Sudan, and he's one of the most experienced in his field, and he's going to just discuss how he's using ultrasound on the ground.
Hello, good evening. From my side is a little bit like 7 p.m. now. I hope you're getting me.
Yeah, we can hear you.
Yeah, okay. My name is Isbon, and thank you very much for introducing me. I'll quickly just go touching basics on the update of MSF projects in South Sudan. So far, MSF, which is Doctors Without Borders, they are humanitarian organizations that work in remote locations within the country. And of course, the country is a very difficult place. We have very bad road conditions. We have insecurities happening everywhere. So it's really very hard that MSF goes down to the remote places to go and offer services to the population that's in need. So in the country, so far we have 8 MSF projects in the country, and all these MSF projects, they are distributed in different locations within the country. Some are really in a very difficult positions, and some are in a little bit stable situations. So it's really like variable. Based on the POCUS training that we are trying to do, by the end of this year, if everything goes well, we should be able to train, able to conduct 7 trainings in different MSF projects. And also in that, we will be having a total of 84 field staffs, that is clinical officers, medical doctors, and midwives. So all these are the groups that we target to be trained in POCUS. In all these MSF projects, we have very big problem with the diagnostic capabilities. Like in most of the settings, like a basic MSF project will have basic laboratory diagnosis, things to do with the malaria rapid test. We have syphilis rapid test. We have Kalazar. We have HIV and AIDS rapid test. But we don't have possibility of X-ray, CT scan, and MRI. Those ones we are not able to achieve them at all. So few of the projects also they have surgical capabilities, but others will not have. Also, they have to coordinate with other organizations in order to facilitate the surgical activities. The referral system in the country is completely down. Most of the referrals are done by car, and especially during rainy seasons, you can spend up to 8 hours to transport a patient from one location to another because the roads are really so bad. And so far in these dry seasons, it's a little bit fair because sometimes you can spend up to 4 hours. That's like kind of a fair situation for us, but it's really still very difficult when you have a very critical patient to refer. So in this kind of situations, MSF also decided to initiate a possibility of if they can transport patients by plane, and which is not also very ideal because sometimes the airstrips are not really so good for landing. So it's really a very big challenge for us to refer patients here and there. And this kind of situations typically, for example, if you need a patient to get an X-ray from a different location, this is where we are going to face a little bit of tough situations in this kind of manner. Most of the morbidities that we experience in our projects, we have malaria, malnutrition, pneumonia, TB, and HIV, emergency obstetrics, and also we have cases of gunshot wounds, as there are a lot of cases of also intercommunal fighting within the country. So as there is no X-ray or another big diagnostic capability in our country, or in most of the projects where MSF is working, so which is very useful, suppose for pediatric lungs and other conditions, for example, like fractures, we needed really X-ray very much compared to ultrasound. But the use of POCUS at the patient's bedside, just like the stethoscope, it has helped us a lot to answer specific questions that arise during our encounter with our patients on daily basis. So we use ultrasound or POCUS at the bedside of the patient to answer some of these questions, like in cases of trauma cases to do with patients with dyspnea and hypoxia. We have mothers with the PV bleeding, and then we also in procedure guidance when we need to do a procedure like thoracentesis or paracentesis, we also use ultrasound guidance to help us to reduce the risk of more injury. So we also have what we call Msf Telemedicine, is a platform that we use to interact with our specialists all over the outside the country. So we have POCUS specialists that are like people who are cardiologists, obstetricians. So these guys are like, they are volunteering to help us in the field. So what we do normally is that we obtain images that are beyond our context, and we try to send to them, and they will be able to answer for us, interpret the images, come up with the diagnosis, and also advise us on which kind of management plan we should be able to proceed for this kind of patients. During all this process of using ultrasound, we have observed that ultrasound or POCUS has given us a lot of achievements, so a lot of benefits behind POCUS. One of them is that we have quick diagnosis. So imagine you seeing a patient that is having severe respiratory distress, and you cannot understand whether the problem is arising from the lungs or arising from the heart. So having the skills of point of care ultrasound and picking the machine and going to the bedside of the patient and scanning the patient right away will quickly able to differentiate for you if this case the origin is from the heart or the origin is from the lung. Two is that it can be done anywhere, from, for example, at the bedside of the patient. And also it is portable, so which means that everywhere within the hospital you can carry the ultrasound and perform it anywhere without any restrictions. Also, it improves our patient's care and decision making, made very easy. So once you get the diagnosis that this is, for example, this patient could be, the heart is contracting very slow, which will tell you that this patient is having poor contractility and it's definitely is a case of heart failure, it immediately gives you a clear initiative and makes you to treat the patient with the confidence, because you have no more doubt that this patient is a clear case of heart failure. And then is also easily integrated into clinical skills. So like really we try to advocate for our clinicians that you should treat ultrasound as a stethoscope. So when you do history, proper history taking, proper physical examination, and then you do some little bit of laboratory investigation if necessary. And then when you perform ultrasound, it makes it very easy for you to integrate it into your clinical activities instead of like using it as a sonographer kind of approach. It also reduces the complications during procedures, so which is also very useful, as been explained by our colleagues in the previous by the previous speakers. It's really very useful that it reduces the risk of injuries or complications to our patients. Then also the model we have is that it is very easy to be learned and applied anywhere. So the models have been reduced to a very significant level that it is easily understood by the patient, by the trainees. For example, what we mostly do is that we do a little bit of lecture and we go mostly on intensive hands-on training. So whereby our trainees have to really hold the probes very much compared to instead of just giving a lot of lectures to them. And then again, of course, ultrasound, when we compare to the rest of the other diagnostic materials, is that ultrasound is more cheap and is also affordable, which is much very good in our settings. We also face a lot of challenges when we try to implement POCUS in all our projects. Of course, one of our major objectives is that we wanted every clinician, like every doctor, every clinical officer, every midwife in the field should be able to perform POCUS by themselves. But this has been not going very successfully, because one of the challenges we are facing is that we have staff rotations. So sometimes you train staffs, and then when you're coming for the next session of the trainings, you'll find that the staffs have already left the project. So it's like project staffs keep on changing here and there, because some of them, they just feel like it's time to leave and we cannot stop them, so they will have to go, which means that when we come back, we have to start the training from afresh from the beginning. Second thing is the equipment maintenance, which is one of the difficult things we are facing all the time. Like currently for South Sudan, I have one machine, which is the Lumify, which is a form of ultrasound that we use in Android phones. So this Lumify, now one of my probes is broken, and we contacted the manufacturer, who is in USA currently, and they have sorted out that the probe is damaged, so they need to replace. Now they have replaced the probe. They have one probe with them that need to be sent to South Sudan, and I need to send the one that is broken back to them. So with the current situations of the COVID pandemic, most of the offices of the Lumify in USA, most of them are closed. Like in New York, they are closed. So one of my colleagues who is there in New York has to go personally to the office to go and pick the probe and bring it back with her, and she has to find an expert who is coming to South Sudan in order to deliver this to me, and also I have to find an expert also to deliver this personally to her, and then she will take it to the office. So you see, this kind of processes is like a very long one that might take 2 weeks, may take even months to accomplish, which is one of the biggest situations that we are facing. And then we also have time to scan. Like most of the times, of course, our colleagues are normal clinicians that are doing their normal duties, but again, they have to do these extra activities for their colleagues. So for example, in most of the projects, not like out of 10 clinical officers, we might train 5. So the rest of the 5 clinicians, they might depend on the 5 which are trained in order to perform ultrasound for them. So you can find that they have to sacrifice extra time and extra energy in order to scan and cover up the needs of the whole hospital, which is one of the biggest things that we are facing. And then the other one is changing management. So for example, of course, we have most of the management teams, the international staff, so they rotate time to time. So as they rotate time to time, some go, those who already in the system, they have understand how the POCUS program goes, and then very soon they will leave the project and go, like the mission ends, then we receive new managers. So these new managers also, it takes another long time to also introduce them, to also educate them on the POCUS program, which is kind of like one of the biggest things that we are facing most of the times. we also look at possibilities like what we can do in order to make the POCUS program, or what will make our trainees to use POCUS more frequently or more easily. One of the things is we need availability of machines and of course their maintenance. So if these machines are being available in our projects and the maintenance route has been established clearly, I think it will encourage people more to use ultrasound, because sometimes if the ultrasound breaks in the project, it's very difficult to take it for repair. And then we also need more trainings. As I said, our objective is to make sure that everybody, like the clinical officers, the medical doctors, and the midwives, they receive trainings for themselves. So each person should be able to perform ultrasound by themselves. So this one we have not yet achieved, which means we still need more trainings, which means that we still need more budgets for that. We need more machines. We need more trainers to do that, which is again one of the biggest things, because I'm currently the only trainer for the country who is trying to run around the country to do training. So this is another biggest thing that is still we need to discuss about that. We also talk about improved internet, which is one of the biggest things that is most important, because we use telemedicine and we need to upload the images. We need a very good internet. So if internet is there, it makes our life much easier to again upload images. We have data tracking system. So again, we are trying to implement POCUS data all over the projects to make sure that they produce for us data and we're able to track how our trainers or trainees have been performing in the projects. So lastly, the training model part. Of course, POCUS is not part of the routine medical education in our country. That means that our medical doctors and clinical officers, they graduate without any POCUS background. So for this matter, as we are trying to improve diagnostic capabilities in MSF projects, so MSF decided to implement this kind of field-based ultrasound training, which is focusing on national staffs to improve their capability on diagnosing of their patients. So we aim also to create sustainability skills in the projects by implementing the POCUS training. So most of the applications that we do is we have, which we call extended focus assessment with sonography in trauma, where we look at patients, if patients that have trauma, if they have any free fluid like internal injuries, which will tell us that maybe they have intra-abdominal bleeding. Pulmonary, where we look at the heart and the lungs to see if we can see any thing wrong with the heart or the lungs, like consolidations in the lungs or any pleural effusion in the lungs. We have also fracture applications. We have soft tissue, where we look for cellulitis, foreign body, and abscesses. We look for FASH. FASH is where we look for focus assessment with sonography in HIV. So these are where we look for extrapulmonary findings in HIV patients. Then we also have the ones we look for, the models of acute abdomen, where we look for intestinal obstruction, interception, and appendicitis. Then, of course, lastly, the procedure guidance. So what we do in our model of training is that we have a 4 weeks training, whereby the trainer has to go to the field. He has to spend there 4 weeks with the trainees. And most of the times we have like 15% of like short lectures, and then we have 15% of hands-on training. This is whereby, as a trainer, you try to hold the hands of the trainee to show him how the times the trainee has to be scanning all the time. Like 50% most of the time is given to the trainee to scan. And then we have the 20% part of it, whereby after scanning, we come and sit together with the trainee. We try to look at the images and try to see which are the quality images he has, and he has to interpret for us and see if there is anything wrong. So these kind of things are the one that is helping us to train our people in the field. And at least for someone to become more effective, we always at least advise that we give, if each person has to receive 2 trainings. So if you receive 2 trainings, that means that at least you can have that initiative to be able to scan independently. And again, with that, we have to also do a long-term follow-up, whereby we also ask the trainees in the field, for example, they have to scan a patient, and then they have to give us send for us 5 images through a USB, and using their logbook, they will send it back to me in the capital, and I'll be able to review the images and review the logbooks and mark them, and also send for them the feedbacks. So normally what we do is that at the end of the training, we try to certify them. So we certify the trainees. This is the MSF certificate, standard certificate that we give to the trainees to certify them that they can use ultrasound within the MSF premises or within MSF projects. But of course, further discussions are still going on to see how we can certify these guys at a certain level where they can also be recognized in other settings of the government or even outside the country. These ones are still under discussions. Of course, when I was using POCUS in one of the MSF projects, there was very interesting cases that I found. There were so many of them, but I have 2 that I will be able to post. And these 2 are all cases of intussusception. So these are patients they came overnight. One is 10 months old female, and the other is 14 months old male. So these patients, they were admitted overnight by one of my colleagues that they were having diarrhea and they were having severe dehydration. And most of them are kind of semi-conscious. So these patients stayed overnight. When it comes in the morning, during the time of handover, I was the one who was working in ICU that day. So I had to listen to their stories. And after the story was told to me, and I was having this differential of intussusception in my mind. So when I went to the ward, the patients were actually next to each other. So I started taking history and examining the first.
I'm not sure if we're going to get him back this time. I think we might have lost him. All right. Well, I don't mean to cut him off because I was really excited to hear about his cases, but I think we might have lost him, and I think that really shows, I think, one of the problems that we have with global health and international medicine. I'm going to go ahead, and I know that we're over time, so thank you for all of you who have been able to stick around with us, and we'll just finish up. I did want to mention that under the leadership of Dr. Erica Constantine, P2 has a global health committee, and here are some of the projects that they've been working on. And of course, Dr. Constantine has been working with Dr. Henwood to establish a relationship between P2 and PURE. And if you are looking for more information, please go to the website. All of this is listed out really beautifully. And just finally, just a couple of announcements from the network. We had discussed at the last meeting instituting membership dues. This will be we'll send out a newsletter to discuss more in depth, and this will include webinars. Oh, sorry. Just close. This will include webinars, educational materials that are in development, POCUS database, which ultimately the goal is to be used for future studies, and other research resources. And of course, there will be reduced fees for trainees and members in resource limited settings. I also want to mention that the elections are coming up for executive board members for the next cycle. And this includes our communications officer, treasurer, education committee, and global health committee will now be 2 separate positions. And conference committee chair is going to be 2 members instead of 1. Our next webinar is going to be Tuesday, May 25th at 11 a.m. Eastern Standard Time, so please mark your calendars for that. And thank you so much for joining us. Really excited. Again, thank you for all of our speakers. You guys were amazing. I learned so much. And I know that we're going to have plenty of people reaching out to you because of all of the wonderful information that you shared with us today. And if any of our speakers are able to stick around for a few minutes, I know that there were a few people who did have some questions. Unfortunately, we didn't get to everything that we were trying to. So if you have a few minutes.
I have a few more minutes if we want to answer any of the questions in the chat. I'm happy to.
Okay, so Dr. Aspler.
Hi, everyone. Sorry, I'm sure everybody's needs to get on with other meetings. I actually have another meeting that started at 1, but it's fine. So thank you, everybody. I learned so much. It was so inspiring. And I'm adult, so I'm a little bit of an imposter here because I know this is community pediatrics, but I'm involved with helping start an advanced curriculum with the adult POCUS program at Addis Ababa University. There's a team of 5 of us, 3 staff who are Ethiopian staff and 2 U of T staff. And I just wanted to put it out there in terms of really establishing that local infrastructure. If anybody wants to have a discussion about their successes and challenges with engaging the hospital leadership and Ministry of Health in supporting the infrastructure for not only purchasing the equipment, but for when it breaks down, kind of having that mechanism or having somebody locally who's kind of responsible for the equipment. And I'm wondering if anybody has experience. I know the Butterfly is new and they don't have a regional supplier in a lot of areas. And we've already had, like in Canada, some of our machines had to be sent back. I don't know if anybody has experience with that. And I'm also just curious more about teleguidance in the COVID area. I know it's a kind of another area. And we also use WhatsApp and Telegram, but I'm just curious others' experience as we're switching to virtual global health education. Those are my 2 questions for the speakers. Thank you, guys.
I think just in terms of the engagement of hospital leadership and the Ministry of Health, I think that these challenges are fairly universal in what we have sometimes in our own departments, in equipment maintenance, who's the point person for something, who's taking responsibility for that, and then investment. So I think that, developing from my perspective, the relationships with both hospital leadership and in the appropriate context, the Ministry of Health can be very helpful in an understanding of what goes into this and the impact that ultrasound has at the point of care in settings where you don't have a lot of other resources. I think that's where a lot of my work has focused, has kind of moved into the research space a bit in that we also need more outcome data to support scaling this in a significant, in ways that larger funders would understand this. I think there's not a lot of great data to actually support really large investments in the global space. And again, some of that work that I'm doing in regards to ultrasound for TB, for example, I think we are still in a place where we have to make the argument in terms of the cost benefit, and then engaging at different levels. I think those relationships, the personal relationships, are of critical importance to really understanding ultrasound and the impact, because I think sometimes people just, see it as another piece of equipment, but don't really see how it transforms care. And I think making that clear is an important point in advocacy of getting support for equipment. And then the question really ultimately ends up being, is there actually, any budget coming from anywhere, or is that something that you have to seek grant funding for? I've worked in context with the Ministry of Health and without Ministry of Health in setting up programs in different countries, actually kind of half and half in the programs that I've been doing. And there's obviously pluses and minuses. There can be a ton of bureaucracy and challenges and barriers associated with working with Ministries of Health. Can also be hugely helpful to have the Ministries of Health, on your side, or advocating or finding space in those budgets at those levels to incorporate something on a national scale. So I think that's a little bit context specific. I know, Anne, you're in Ethiopia, and the size of Ethiopia, is a different thing than the size of the Ministry of Health in Zanzibar, for example, and how I'm engaging them. What we did in Rwanda is a smaller place versus Uganda. So I think that the relationships are important, and finding ways to advocate and to make the argument is important to get the budget, but it also depends if there's actually a budget there to be had or not.
That's helpful. Thanks, Trish.
Mm-hmm. And then I think the device, I don't know if some of the other speakers want to speak to it, but the device redundancy, I think, is also really important. There's the advantage of these, handheld, very portable devices, but they're newer generation, and we end up, with tech issues and no local fix. So if you don't have a backup device, if there's one device that the entire program is counting on, then there's a fair chance that you're going to be out of pocket with ultrasound for some period of time if that device goes down. So trying to have especially when they're lower price point devices, multiple devices, in the anticipation that one of them is going to go down at some point, and then at least there'll be something in the rotation while that one is getting repaired. And local biomedical engineering is also, I think, very variable by the setting, but thinking about ways that you can engage those groups at the beginning so they know who you are, and then they end up potentially being a lot more helpful when something breaks down because they know you and the equipment that you're working with, and they might be able to try to find a way if there's capacity for local repair. A lot of these things actually need to kind of go back to the manufacturer for attention. So the question is it something that is locally repairable? And if there's not a regional office, then this continues to be a major challenge, I think, for this type of work when we don't have a lot of bioengineering support.
That's great. I'm sure people want to leave. I don't want to keep anybody. I also am just wondering, in terms of developing your local leadership's soft skills, so that's, for instance, helping them with making virtual content. So it's funny, like, I think as you're establishing these programs, we now have a couple of experts who are good at all of the basic applications, but now getting them to be excellent educators and running the program is kind of the stage where we're at. And even just helping them with PowerPoint design or uploading clips or making a virtual. I'm just wondering if the group or the Hive here has any, I don't want to say experience or resources, or like, I don't know if there's other people who are at that phase with their projects where they're really trying to remove themselves as much as possible. And if there's, I don't want to say there's any database of soft skills, like this applies in all fields of emergency medicine. How do we teach junior faculty in resource limited settings to kind of develop a lot of those research teaching skills? I don't know if anybody has any thoughts about that, because that's one of the areas we're really working on.
I don't know if the other speakers are still on. If they want to answer, I'm happy to answer. Otherwise, but I would.
No, I think they're all gone.
Okay, so and we have done programs like that, particularly with our team in Rwanda, in terms of the specific train the trainer about the content, because one, with ultrasound, we know people make all the same mistakes every time they pick up the probe. They're looking too shallow in the pelvis. They have this angle off with the phased array probe. They're not angling correctly to get the clear view of the pleural line. So really focusing on programs where you teach people how to teach the particular aspects of these are the things that every new user is going to do when they pick up the probe that are wrong, and this is how you're going to verbally coach them through it, I think is one. And then two, you can recruit a lot of faculty that are just good at giving talks and giving presentations and slide design, and they don't actually have to have ultrasound skills, but they can spend some time with your mentees in trying to perfect their putting together of a lecture, how you deliver a lecture, having less words and having more pictures, talking through things, having ways that they prompt things. And so I think that there's actually space to leverage, the people that, maybe in your departments that are the best at that to help with this. And this is a great platform for, teleeducation and Zoom, and everyone's used to being in a virtual room. And so they don't need to be an expert in global health that's traveling. They can just recognize, that they're talking with an audience that might not be as familiar with PowerPoint or giving talks and how to kind of put those things together. So I think leveraging different people based on their skill set to help, offloads people that are leading programs where you have to be very skill focused, for example, of skill transfer. You're going to have to be the one that says, this is what everyone does wrong with their probe. But you can try to recruit people that might be, the best at education and lecture delivery and giving them tips and tricks. Because I think the mentorship thing, I think Vincent might still be on the line, but I think the mentorship thing is really critically important, because those leaders have to advocate with their leadership, right? Vincent has to talk to his leadership at his hospital and with the Ministry of Health ultimately to sustain the devices and support for the program, or incorporating ultrasound into a pillar of their emergency medicine curriculum. So teaching them how to frame the arguments and the advocacy is all, I think, part of things that that are important to growth of a program.
I can keep going with the questions. So you're probably gonna have to cut me off because
I
wanted
will have to jump off in a second.
Yeah, we have 3 grants to do apparently in 2 weeks. But I'm just wondering, in Rwanda, where I know we lost that speaker, do you know what their ultrasound leadership structure is? Like, do they have one POCUS director with, because I know even in North America, different POCUS programs have different structures, but do you know what their end structure is right now?
Vincent, are you still on the line? Because I'll let Vincent answer, but essentially many of their leadership in emergency medicine are also heavily ultrasound trained. And it's just really integrated into their residency program, the way that the department functions. Vincent is essentially the point person now on kind of devices and interface on the ultrasound curriculum. So he's really functionally that point person, but that has kind of changed over time depending on what the leadership structure is for the department and the residency. Because we've been working there for really since before EM was born, and so it really became very integrated into the practice, and ultrasound leaders became the leaders, and that's sort of how it evolved there. But I think having a champion, if there's not a context where it's so woven into the curriculum and the practice, is really critically important to have the point person that's going to be, managing the devices, interacting with trainers, making sure people are showing up, for training, making sure people are uploading their images for quality assurance. So I think there has to be a point person. In this case, it's helpful because it's the leader of the program as well.